Yes.
So we finished yesterday at the end of a stopgap programme, and as we have discussed, that was a precursor, in the mind of Dr. Lane, to a full redevelopment of BPL, something that you have heard considerable evidence on, particularly from Dr. Walford, Lord Clark and Lord Fowler. I'm not going to repeat that evidence, and I'm not going to go through in any sort of detail the way in which the full redevelopment of BPL took place. There are a couple of points that I will make here because they will assist later when we are looking at some of the data. The first is that the redevelopment of BPL, the full-scale redevelopment of BPL, was informed by the estimates that we looked at yesterday, and particularly Dr. Lane's estimates of 90 million international units by the mid-1980s, and a ceiling figure of 120 million international units, which he foresaw as the size of the redeveloped BPL in order to cater for an increase in demand. He wasn't necessarily saying that demand would get to 120 million international units. From the documents that we went through with Dr. Walford, Lord Fowler and Lord Clark, we can see that when in the planning stages of BPL, the size of the new development is usually expressed by reference to the amount of plasma per annum that it will fractionate. Treasury approval was originally given for a site fractionating 400,000 kilograms per annum. Later, that is increased to 450,000 kilograms per annum, and that is a figure that we will pick up later in the tables. We understand that to have been on the basis of the types of estimate that Dr. Lane was making about usage. There isn't a straight line to be drawn between the amount of international units to be created in, for example, 1989, and the amount of kilograms of plasma to be inputted as estimated in 1979, because there were a number of variables along the way, in particular, a hope, an expectation that yields would improve as the plant developed and as techniques improved. As we will see, in fact, yields decreased because of the introduction of heat treatment. Construction began on the redevelopment of BPL in May 1983. The original estimate for completion was July 1985. That slipped over the years to the summer of 1987, so approximately 2 years slippage. The date...
So it doubled, in effect. May 83 to July 85, 2 years. July 85 to summer 87, 2 years.
Yes, yes. That's the construction period doubled, yes. The estimates for achieving self-sufficiency, they shifted from 1986 to 1989. Now, the difference between the completion of the plant and achieving self-sufficiency is explained by the fact that there was an expectation that the plant would take some time to get up to full speed and up to full production. That is borne out by the figures that we see later. The cost of the project increased from £21.1 million in 1982 prices to a capital cost limit of £60 million as granted in 1986 at 1986 prices. I think the ultimate price tag came in slightly under that, but that was the cost limit that was allowed. There was an additional £7 million to be spent on what were considered to be essential extras in 1986 prices. And we have seen from some of the documents the contemporary views of ministers decrying the lack of cost control. Lord Fowler told this inquiry at paragraph 4.82 of his statement that the overspend on the project reflected poorly on the department. He suggested a number of factors contributed to the delays in the expense, and the wider documents also suggest these kind of factors. They are the underestimation of the initial project during the tender stage, the complexity of the plant and of the build, the various redesigns that took place during the project, in part due to the new technology that was becoming available, and in part due to the design and build approach that was taken. So there was an element of designing whilst the build was ongoing. There is also evidence to support poor management by the CBLA and a lack of oversight by the DHSS. Lord Fowler did also point to three, what lawyers might call points of mitigation about the project. The first was that although, as you've said, sir, the length of time of the build of the project was longer than was anticipated, a submission from the 29th of December 1986, an internal DHSS submission, assessed that the building was still completed 2 or 3 years earlier than would have been the case with what were termed conventional methods. So I think that means instead of using the design and build approach, a normal procurement approach had been taken. And the assessment from 1986 was that would have taken even longer. The second point is one which is taken from a minute from Baroness Trumpington, a minister in the DHSS, from the 20th of February 1987. And she had been highly critical of the way that the project had been handled. But she said in her minute, and the reference is WITN 07711068, that it was, and I quote, some small comfort that the new chief executive of the CBLA, who is not implicated in the project's history, has told officials that on the basis of a lifetime of experience in the pharmaceutical industry, he would say that the building represents value for money. That is from 1987, at a time when the full cost of the project was known. The third point that Lord Fowler made is a simple one, that he and his colleagues continued to sign the cheques. They continued to pay for the project, and £60 million worth of spending in 1987 would amount to about £180 million worth of spending by 2021 prices, the date of Lord Fowler's statement. He says, and I quote, "It was a very considerable level of investment, particularly given the financial pressures on health spending. It was met from the health budget, and it meant that that spending on BPL was given priority over other pressing areas as well." That is from paragraphs 4.81 and 4.83 of his statement, and also the transcript of the 21st of September, pages 116 to 118. That is all I'm going to say about the redevelopment of BPL. We will come back shortly to look at how that redevelopment affected the amount of plasma that was fractionated and the amount of blood products that were produced at BPL, at least in terms of factor rate. I'm going to turn briefly to heat treatment, and I'm touching upon it only briefly because I know that Ms. Richards is going to be going through many of the documents with you in due course when looking at the evidence of Dr. Smith and of Dr. Lane, and I'm sure it is something that we will pick up with Dr. Snape as well in a couple of weeks' time. So what I'm going to try to do now is just provide a chronological framework that the later evidence is going to sit within, and it may be that the later evidence either throws into some doubt some of these dates, it may be that it qualifies them, it may be that it supports everything that is said here, but what I am not trying to do is to supplant that later evidence, just to give an introduction, as it were, to it. This is taken largely from the written presentation, and it's from paragraph 230 onwards. I won't be taking you to many of the documents. I'll leave that to Ms. Richards in due course. BPL and PFL had introduced RIA testing for hepatitis B antigen from 1976. Initially, they relied upon a commercial test, but over time they developed and refined their own test. And we spoke yesterday about how the single plasma pack was introduced. Part of the rationale for that was that it would be more amenable to sensitive testing for hepatitis B antigen. In late 1980, according to Dr. Lane in his 5th draft proof of evidence, he consulted with senior staff about the procedures that were available for viral inactivation. The context of that evidence suggests that the ongoing work of Dr. John Krask and the hepatitis working group was influential in shaping Dr. Lane's thinking at that time. On the 13th of February 1981, Dr. Lane sent a memorandum to staff at BPL inviting them to set out projects for consideration for research and development. In response to that memorandum, a proposal was put forward on the 27th of February 1981, which was entitled, and I quote, "The development of methods for production of coagulation factor concentrates with reduced risk of hepatitis transmission." That proposal from a more junior member of the BPL staff noted that the advances that were being made in hepatitis B testing and reducing the risk of hepatitis B infection, and said that that highlighted the importance of the risks of non-A, non-B hepatitis infection. To quote from the proposal, it argued that, quotes, "The significance of a product free of hepatitis risk cannot be ignored, and it is essential that BPL/PFL be well placed to take advantage of such developments." The reference for that proposal is CBLA 301291. Dr. Lane subsequently wrote in his 5th draft proof of evidence that this proposal marked the start of a move towards a viral inactivation program at BPL and PFL. On the 4th of March 1981, so the following month, Dr. Lane put forward that proposal as one of 6 projects that he considered to be appropriate for central funding. He put that forward to the Scientific and Technical Committee of the Joint Management Committee, a body that we were looking at yesterday. Something that Dr. Lane says in his statement is that throughout 1981, there is an issue about trying to get research projects funded, in essence trying to get central funding from the DHSS to support such projects. On the 27th of July 1981, Dr. Smith produced a memorandum setting out various measures that could be used for reducing hepatitis infectivity in blood products. It is important to note at this stage, sir, that heat treatment is one of several options. It's always tempting when we are looking back to pick out the one that eventually comes to fruition, but it was one of several at the time. Interestingly, in that memorandum on the 27th of July 1981, Dr. Smith referred to the Behringwerk claims about their heat-treated product. There was no reference to that in the memorandum of the 27th of February, but there is in Dr. Smith's memorandum of the 27th of July, although Dr. Smith was at pains to point out that there was no reputable evidence for the claims made by Behringwerk at that time. Dr. Smith said in his memorandum that he had, and I quote, a few ideas on how to start, but this might more probably be an R&D project. And my interpretation of that, and I stress it as my interpretation, is that might be, again, going back to this issue of trying to get central funding for this type of work. The reference for that is CBLA 301414. Dr. Lane returned to the Scientific and Technical Committee on the 24th of November 1981, and a discussion took place on the inactivation of hepatitis and BPL products, which drew heavily on Dr. Smith's work. It may even have been Dr. Smith who was giving that presentation. The summary of the various methods that were thought to diminish the risk of hepatitis at that time included screening, limiting the size of plasma pools for certain products, neutralizing or absorbing virus with an excess of hepatitis antibody, vaccination, virus removal through precipitation with polyethylene glycol, and viral inactivation through various methods, including but not limited to heat treatment. So those are the types of areas being discussed. In his fifth draft proof of evidence, Dr. Lane said that no time was spent researching viral inactivation of viruses by heat treatment in 1981, and that such work only began in 1982. The exact nature of that work in 1982 isn't clear to us, or at least isn't clear to me from the documents that I have seen. In his draft proof of evidence, Dr. Smith stated that from November 1982, he was engaged in liaising with the Protein Fractionation Centre on discussions about how to stabilise factor 9 for heating. BPL was also involved during 1981 and 1982 in a collaboration with Spaywood on polyelectrolyte fractionation. That is something that we looked at during the pharmaceutical section of the hearings and in the evidence of Dr. Sarah Middleton. You will recall, sir, that collaboration was at points a little fractious. Actual experimental work on the pasteurization of factor 9 began in January 1983. We take that from both Dr. Lane's draft proof of evidence and Dr. Smith's. That work was on wet heating, as it's sometimes called, genuine pasteurization, heating in a solution. 60 degrees Celsius for 10 hours was the heat treatment regime that was being used. Dr. Smith said in his statement, his draft proof of evidence, that, and I quote, the results were far from exciting, but promising enough to continue as resources permitted. I will, if I may, just take you briefly to one document which comes from February 1983, CBLA 301781. Please, Paul. This is a document I think that Ms. Richards might be taking you to later, so I won't go through it in depth. But we can see on page 1, it is entitled Proposal to Develop a Hepatitis Safe Factor 8 Concentrate. And we know from the draft proofs of evidence given by Dr. Smith that this is his document. If we could just go and look at the first page, what is written is this: factor 8 concentrates, in common with many other coagulation factors, are implicated in the transmission of at least 3 diseases. Hepatitis B, transmitted by a virus with well-documented marker antigens and antibodies. Non-A, non-B hepatitis, NANB, thought to be transmitted by a blood-borne virus, but for which there are still no reliable markers. Acquired immune deficiency syndrome, not yet proven to be of viral origin, but this is strongly presumed. This is from February 1983. I pause there to note that the previous discussions about viral inactivation have been about hepatitis, and the focus has been on hepatitis. As is said there is a presumption that AIDS is a virus which can be spread by blood as well, but that has not yet been proved.
Well, actually, it says strong.
Strong presumption.
Presumption.
Yes.
If there's a strong presumption, that's equivalent, I would suppose, to probability, is it?
I'll
leave that for others to comment on.
Yes, yes.
It's a question mark at the end of that. Thank you.
The next paragraph says this: the incidence of hepatitis B is diminishing, possibly because haemophiliacs received many batches of large pool concentrates become immune, and partly because of improved screening of the plasma used for fractionation. The incidence of NA-NBH hepatitis, especially on first treatment of mildly affected patients, remains very high, and screening cannot yet be applied for want of markers. NA-NB causes increasing concern, less on account of its acute effects, although deaths have been reported, than because of its association with chronic active hepatitis in later life. So that is what is informing his consideration of the various options for viral inactivation. He goes on to say that factor VIII coagulation activity has always been regarded as exceptionally labile. That is something that we heard from Dr. Middleton and will no doubt be discussed in the coming days and weeks. It is only recently that serious attempts have been made to apply factor VIII concentrates, some physical and chemical processes designed to inactivate hepatitis viruses. As with other concentrates, the options open to fractionators, excluding screening and vaccination, are immunological neutralization or immunoadsorption on solid phase antibody. I paused to note that was the type of work that was going on with Spaywood. Physical removal of infective agents, e.g. semi-specific adsorbents or precipitants, and 3, inactivation by heat or virucides. He then goes through, and I won't go through in detail the paper, but he goes through, if we could go into page 2, please, Paul. First, a consideration of immunological methods. Second, physical removal, which includes PEG precipitation. That's on the next page. Then on to page 4, inactivation, virucides, and then heating. And if we just pick up the bottom of that page, Dr. Smith wrote this: heating is considered the most promising approach to virus inactivation because, 1, it is likely to be of broad application, i.e. conditions which inactivate the exceptionally robust hepatitis B are likely to inactivate other blood-borne viruses. 2, the treatment is cheap, relatively easily controlled, recorded, and scaled up with precision. 3, extensive experience with other successful pasteurized proteins, such as albumin, offers readier regulatory and clinical acceptance than the use of a novel or unfamiliar chemical virucide. So that last point is talking about how you persuade clinicians to actually use the product that you're making. The first point, so you might feel, is relevant to the discussion on the first page about the strong presumption that AIDS was a virus. The next page sees Dr. Smith talk about irradiation, then fractionation of plasma from small panels of accredited donors, and then if we go to point 3, there is a more detailed development of option 2.3.2, inactivation of virus by heat. I won't go through that, but you can see that there is Dr. Smith, in essence, proposing that is, out of the various options that he has surveyed, the one that he would recommend proceeding with. It's also notable from that paper that Dr. Smith considered that the use of accredited donor panels was something that was worthy of further thought as well. That paper was from February 1983, and with Ms. Richards, you will hear about meetings that took place in April 1983 in BPL as a response to growing concerns about AIDS and addressing the question of the role that BPL might play in that. That paper from Dr. Smith may be of some significance when considering that further evidence. I won't take you to it now. On the 23rd of June 1983, so following that paper and following the meeting that I've just referred to, Dr. Smith sent a memorandum to Mrs. Winkleman of BPL and PFL, giving the viral inactivation program A1 priority. As the name suggests, this was, and I quote, most important to PFL's immediate product strategy. And Dr. Lane subsequently confirmed that he approved that authority. By July 1983, experiments on dry heating, the intermediate purity factor VIII concentrate that was manufactured at PFL, showed that heating at 60 degrees did not affect recovery or solubility at 60 degrees, but noticeable deterioration began at 80 degrees for 10 hours and at 75 degrees for 20 hours. These are all, degrees centigrade. So heating through dry heating, the existing intermediate purity product from BFL, a product called 8CRB, at 60 degrees centigrade doesn't seem to affect recovery or solubility, but at 80 degrees centigrade for 10 hours, those measures are being affected, and at 75 degrees centigrade for 24 hours, those measures are being affected. Dr. Snape, in his evidence to this inquiry, said that over the coming months, 3 types of heat treatment at BPL and PFL are developed. The first, HT1, is 60 degrees centigrade for 72 hours. And he says, Dr. Snape says, that that degree of heat treatment was tolerated fairly well by all batches. HT2 involved heating at 70 degrees centigrade for 24 hours. Dr. Snape said that this was tolerated by most batches, but with some penalty in terms of yield and the resolution time, the time that it takes to turn your freeze-dried concentrate back into a liquid. HT3 involved heating at 80 degrees centigrade for 72 hours. And this only became possible following the experimental work that Ms. Richards will discuss with you in the coming days. The second of those regimes, HT2, will be used to heat the initial heat-treated factor VIII that was sent out by BPL on an interim basis in late 1984 and early 1985. So we'll come on to see why that was done. The third regime, the 80 degrees regime, is the regime that was used to heat the product called 8Y, which was issued from later in 1985, and was a product which inactivated both AIDS and non-A, non-B hepatitis. BPL heated factor 9, which was a product called 9A, was also treated with the HT3, the 80-degree regime. On the 15th of July, Dr. Smith produced a memorandum explaining the work that PFL was doing on heat treatment, and also comparing it to the work that was being done at that time by commercial manufacturers. He set out the findings that had been done on the yield effect of heat treating 8CRV. That's the product from PFL. He said that they were encouraging, positive, and showed a loss of no more than about 5% of factor activity. I note that that is about the PFL product. When heat treatment is applied to the product which is being produced at BPL, there is a greater effect on yield, and we'll come to that shortly. Ms. Richards will take you to these documents, so I won't. But I will just read a short quotation from Dr. Smith from July 1983, where he says, and I quote, "Provided we make no immodest and unsupportable claims about evidence of hepatitis safety or overstate our confidence in this as a long-term solution, I believe that many clinicians would be happier to use a dry-heated product than the existing one, and it might respectively be offered on that basis." So what Dr. Smith is saying here, and it is echoed in what he says in other papers, is that commercial companies are producing dry-heated products, sometimes with claims that Dr. Smith does not feel are borne out about hepatitis inactivation. The product that has been produced at BPL, at PFL at that time, he says is equivalent to those commercial products, but it shouldn't be supported by, in his words, immodest and unsupportable claims about evidence of hepatitis safety. I pause it to note that at the time there was no test for non-A, non-B hepatitis, so it was hard to establish that your product had inactivated non-A, non-B hepatitis. The only way that you could examine that was through clinical studies, which obviously would take some time. So Dr. Smith is saying that the product can be offered to clinicians. He expected clinicians might be interested in taking up the NHS heat-treated product, but he is not claiming that it is hepatitis free. It is also interesting, and this is developed in the written presentation, that it is again the presence of commercial products on the market which is helping to drive forward the research that is being done at BPL and PFL on heat treatment. There is a sense that an equivalent NHS product should be provided. Dr. Lane produced a paper entitled, and I quote, "AIDS Progress with Heat Treatment of Human Plasma Products," on the 26th of July 1973. He again wrote that heat treatment was one of only several methods of viral inactivation, but it was the one that was most favoured at the present time. And again, he, like Dr. Smith, refers to or makes a comparison between the product which is coming out of PFL and might be expanded to BPL and the commercial products that were on the market at the time. It says, in effect, that the NHS can produce an equivalent product. That memorandum was tabled at the CBLA meeting of the 27th of July 1983, and the CBLA said that it would be kept informed of progress on this form of product treatment, which it was hoped would become routine by late summer 1983. That didn't take place. It's not entirely sure what routine meant, whether or not that was a reference to an output of product or a reference to the process of heating could become routine within the laboratories by late summer. Either way, it is in October 1983 that experiments began on dry heating at BPL and heating the BPL product, which was a product called HL. That distinction is important. As we have discussed before, PFL is a much smaller laboratory. At this time, it is being used, at least in part, as an experimental laboratory. BPL is much larger, and so you have to scale everything up. It is also producing a different form of intermediate purity product, which might react differently to the heat treatment. On the 7th of November 1983, Dr. Lane stated that BPL had a dry heat-treated product available, and following discussions, it was recommended that this should be subjected to clinical trials as soon as possible. That position was endorsed by the CBLA at its meeting on the 23rd of November 1983. Despite this recommendation...
Just pause there. Yes, so 7th of November 1983, BPL could produce, was producing, had produced heat-treated product, which it did not know would be effective against AIDS, but reasonably supposed it might be.
I can't take you to Dr. Lane or Dr. Smith's thinking about time. I'll leave that to Ms. Richards.
But does that follow from what you've just been telling me?
Not necessarily. There is a feeling that there is a strong presumption by that stage that AIDS is a virus or is caused by a virus. There is an assessment by Dr. Smith that we saw in that earlier paper, that if you can heat treat a product effectively so that it will get rid of hepatitis viruses, then it will get rid of a lot of other viruses as well, because hepatitis is known to be a particularly tough virus to inactivate. What BPL have produced by November 1983 is a heat-treated product that they think works as a factor 8 treatment. So they have heat-treated something without removing the factor 8 activity to such an extent that it wouldn't work. What they don't know is whether or not that heat treatment has inactivated hepatitis. What they also don't know is whether that heat treatment will have inactivated other blood-borne viruses, including the putative virus.
Well, that brings me back to the way I formulated my question. It didn't know that it would work, but there was a chance it might. Was that the position? It seems to be from what you've just told me.
It's a possibility, yes, but they don't.
So it's a possibility if there's a chance it might work. And there's no such chance if the product is not heated, presumably.
Well, it depends whether or not techniques have been applied to it, heat treatment not being the only one.
Yes.
But there is a process which has gone on, which is designed virus inactivation, but it is not known whether or not that process has effectively achieved virus inactivation.
And what they need to check is whether it causes any other damage as a consequence.
That's right.
Yes, I see.
The heat treatment that was applied at this stage, it's not always clear from the paper, and it's perhaps something that we will pick up with Dr. Snape and with others. It seems that it was probably that first level of heat treatment, 60 degrees centigrade for 72 hours, dry heated.
So it was HT1, not HT2?
I think so at this stage, but I caveat that by saying that I can't be absolutely sure, and that is something that we need to explore further in the evidence. Despite the fact that this has been endorsed by the CBLA, clinicians appeared to show little interest in the dry heat treated product, according to both Dr. Lane and Dr. Smith. In his draft proof of evidence, perhaps actually we can, no, we won't, I'll simply read it to you. Dr. Lane said at paragraph 932, and I quote, "A trial protocol was subsequently developed for discussion and agreement with the Hemophilia Centre directors, but this took a long time, and in the meantime, those Hemophilia Centre directors I had already approached showed no immediate enthusiasm to use the new BPL product on a trial basis. Our effort in this regard culminated in our securing 3 patients only on which to try out our new heat-treated product. The trial, in actual fact, never got off the ground. These 3 patients were recipient of heated H8CRV, the PFL product, in 1984.
So that sounds like HT2, if it's HCRV. Does it?
No, not necessarily. HCRV could be heated by any one of those. And in fact, there is an extract from Dr. Smith's draft proof of evidence, paragraph 63, where he says that concentrate was heated at 60 degrees for 72 hours.
That's HT1.
That's HT1.
Yep.
He said that the patients suffered no ill effects, but in his comment there were, and I quote, "no further takers." Dr. Smith's evidence was that after those October and November experiments, dry heating was then virtually shelved at BPL and PFL as a promising option to which they could return while they went on with their work on pasteurization, which was thought would be a more secure way of inactivating non-A, non-B hepatitis. So the focus shifts over to pasteurization. As we heard in the November presentations on pharmaceutical companies, there are different ways of heat treating. Pasteurization, heating in a solution, true pasteurization, was considered to be a more effective way of heating because you get a more uniform heat throughout the product. The comparison that I think it was Dr. Kingdon made was it's like heating something in a bath rather than heating something in an oven. And that's why it's considered to be more effective. And the work that was being done at PFC at this time as well was focusing on pasteurization rather than dry heat. Now, the evidence from Dr. Smith and Dr. Lane about limited take-up from clinicians echoes that of Dr. Kingdon. the sometime Vice President of Highland Division of Baxter Healthcare Corporation. We looked at his evidence, which is also in the form of a draft proof of evidence for the HIV litigation. We looked at that in November. His company had heat-treated its Factor VIII product, Hemophilia, and indeed were the first to get a US license for a heat-treated Factor VIII product, which they got in March 1983. Dr. Kingdon, in his draft proof of evidence, wrote this, and I quote, "Initially, Hemophilia T, that's the heat-treated product, was viewed with some suspicion by haemophilia treaters who were slow to adopt and use the product. There was much concern that the product was priced too high, that it did not prevent the transmission of hepatitis, and that heating altered the Factor VIII in some subtle way, which would lead to the development of antibodies in patients." Turning to 1984 and 1985, as we have seen, the focus switches to pasteurization. There are various experiments done, which Ms. Richards will no doubt refer to in her presentation on Dr. Smith, including experiments on how to remove fibrinogen and fibronectin from Factor VIII during or before or after the heating process. And those experiments led to a series of experiments known as the 8Y experiments, which led to the development of that third level of heat treatment, the 80 degrees heat treatment. The story will be fleshed out in some detail by Ms. Richards. In November, Dr. Smith attended the Groningen conference, and there he heard from representatives of the US Centers for Disease Control that experiments in the United States had shown that HIV was heat labile. And we have looked at that evidence in the pharmaceutical section. I've used HIV as shorthand there. Of course, the terminology at the time was HTLV3, the virus having been discovered earlier in 1984, and then it was spiked. Factor VIII was subject to heat treatment, and it was shown that that inactivated HTLV3. There were then further experiments done on full-scale production of Factor VIII. And the effect of this is that by the autumn, there is robust evidence that HTLV3 is inactivated by heat treatment, and indeed is inactivated by heat treatment at a level which is not particularly high. It doesn't have to get to the levels that one was anticipated needed for hepatitis. On the 12th of October 1984, so before the Groningen conference, Dr. Lane had asked that Dr. Smith, Dr. Snape and Dr. Wesley give, and I quote, urgent consideration to the possibility of introducing as routine a dry heat treating step in the finishing of Factor VIII and Factor IX concentrates. This step would be aimed principally at the elimination of AIDS infectivity, accepting the dubious effectiveness of dry heating in the prevention of non-A, non-B hepatitis transmission. The reference for that is CBLA 301908. The date is the 12th of October 1984. We will explore in evidence the reasons for that date, but effectively that is Dr. Lane saying, let's focus on a heat treatment method which is directly aimed at eliminating AIDS, and we will accept that it may well not work for hepatitis. The heat treatment on the BPL product, HL, was more problematic than on the PFL product, HCRV, in terms of its effect on yield. But a decision was taken that both BPL and PFL would heat stocks of HL and 8-CRV at that second level of heat treatment, 70 degrees for 24 hours, as an interim measure. At this time, there was a growing sense of excitement about 8Y as a product that could be heated at 80 degrees Celsius for 72 hours. But in order to produce 8Y, you had to come up with a slightly different form of concentrate than the existing intermediate purity form of concentrate. So you couldn't simply, it wasn't a case that you could simply take your existing stock and heat it at 80 degrees. That would have led to both a loss of yield and potentially a loss of factor VIII activity. So you had to start from scratch, build your new concentrate, and then heat it at 80 degrees. So as an interim measure, a decision was taken that the existing stock of intermediate purity product would be heated at that lesser level, 70 degrees for 24 hours. And that was a response to AIDS, and it was accepted that heating at that level may well have no effect on, or little effect on, non-A, non-B hepatitis. That decision to take that interim step was agreed with the Hemophilia Reference Centre directors at a meeting at Elstree on the 10th of December 1984. On the 14th of December 1984, Norman Pettit of BPL wrote to the regional transfusion directors in England and Wales, setting out the origins of the BPL heat treating programme and the approach that was to be taken to heat treated products in the coming months. He said that BPL would not issue supplies of non-heat treated factor VIII in December 84 or January 85, but the product would still be available on request. So it is not going on general issue, but clinicians who wanted non-heat treated product could request it. And regions were asked to inform BPL about their proposed policies. In a sort of a reference for that is CBLA 301955. In a later letter, dated the 24th of January 1985, Dr. Snape informed Hemophilia Centre directors that it was anticipated that the heat-treated product that would be provided to them would be about 50 to 60% of the amount of unheat-treated product that had originally been planned to be provided to them. And that was as a consequence of the loss of yield in the process that was involved. You lost some of the product by heat treating it. That figure is also used subsequently in a letter by Mr. Pettit. The references are CBLA 301998 and CBLA 302154. We'll come back to the effect that has in due course, but we can see it in an indicative sense only on INQY 40336, page 42, please, Paul. This is the bar chart, if we could expand that, please, that we discussed yesterday, the one that has been created by the inquiry legal team by using a graph that came from the UK Hemophilia Centre directors in 1990. I stress again that this is indicative, not precise, because we don't have the underlying figures, but we do have enough to be able to draw up something which shows a trend. We can see, if we look at the period from about 1980 and 1981, and we're looking at the blue blocks, the NHS factor VIII, we can see an expansion between 1980 and 1983. That is a consequence of the stopgap programme, and then a further expansion going up to 1984 again, the stopgap programme working its way through. In 1984 to 1985, you see a decline in the amount of NHS factor VIII that is available. It is our understanding that the principal reason for that decline is this loss of product as a result of heat treatment, and the 50 to 60% that Dr. Snape referred to in his letter to the Hemophilia Centre directors. And we can see it picks up again a little in 1986 and 87, and we'll come back to the later figures. You will see that as a consequence of that in 1985, there is a small overall decline in the use of factor VIII products, but there is a large expansion in the use of commercial factor VIII products, many of which would have been heat treated at that time. We can take that down now, Paul, thank you. According to Dr. Lane's fifth draft proof of evidence, after the 1st of February 1985, only heat-treated factor VIII concentrate was issued from BPL, but that is an issue that may be explored later in some other evidence. In the same month, February 1985, 8Y, the 80 degrees heat-treated product, was first issued as part of a stage 1 trial, that is a trial to test the safety and objective efficacy of the product. The focus of the research efforts at BPL have been switched to 8Y. The heating of the 70 degrees of HL and HCRV is a production issue. The research is going into 8Y because that's seen as the most promising method of treatment. February 1985 saw the stage 1 trial. From April 1985, 1st of April 1985, 8Y became available on a named patient basis. There is a discrepancy in the evidence about when 8Y became the only factor VIII product issued by BPL. According to Dr. Lane, that is in August 1985. Dr. Snape puts the date at 18th of September 1985. So a small discrepancy. It took longer for BPL to develop and release its heat-treated factor IX product, which is called 9A. And that delay seems to have been largely because of concerns about thrombin generation, so a concern about the effect that the drug, the product might have on those who take it. 9A was heat treated at 80 degrees Celsius for 72 hours. It was not generally available until late September or October 1985, according to the evidence that we have from Dr. Smith, Dr. Lane, and Dr. Snape. Before that time, BPL had continued to produce some unheated factor IX, 9D, but it's unclear at the present time how much of that was actually being issued to Hemophilia Centre directors and whether or not they could request it on demand. But we can see from a graph from the UK Hemophilia Centre directors the effect on factor IX. If we could have, please, Paul, HSOC 40596. So these are the annual returns for 1990 from the UK Hemophilia Centre directors. If we could go, please, Paul, first of all to page 16. This is the factor VIII graph showing the amounts of the total amount of factor VIII used, the commercial factor VIII, the NHS factor VIII, cryo and plasma for the period from the late 1960s to 1990. that is the graph upon which the bar chart that we have been looking at is based. I'm going to take you to I hope, more user-friendly version of that in due course, but I'm just showing you now that is what the bar chart is based upon. If we could go to the next page, please, and come back to look at the distribution of those figures in due course. If we could turn that around, please. This is the equivalent graph for factor 9. We can see, represented by the clear circles, the total amount of factor 9 used, and we can see a fairly steady upward growth. We can see with the line with the X's in it, the amount of NHS factor 9. For most of the period from the early 1970s until 1984, 1985, we can see that those two lines are fairly close together, very close together, indicating that almost all of the factor 9 product in the UK was produced by the NHS. And that is confirmed by the fact that the other line, right at the bottom, with a clear triangle, that's commercial factor 9. We can see just a very slight entry of the line in 1973 and 1974, when it may or may not be there in very small level, very, very low level, going into the early 1980s. The other product that was used for haemophilia B patients was plasma, and we can see that was used almost, or in fact, more than NHS factor 9 in the late 60s, and then there is a crossover between 1970 and 1971 where NHS factor 9 concentrates are used instead of plasma, and plasma use declines through the rest of the 1970s and becomes minimal and disappears in the early 1980s. In 1984, we can see that the NHS factor 9 decreases sharply in terms of the number of units issued, from somewhere in the region of 12 million to somewhere in the region of 8 million. At the same time, we can see that the amount of commercial factor 9 increases, and for the first time becomes clearly visible on this graph. It goes up to approximately 3 million international units for the year 1984 to 1985. And then between 1985 and 1986, the inverse happens. So NHS factor 9 goes back up again, not quite to its previous levels, but towards them. And commercial factor 9 declines, not quite to nothing, but towards nothing. And that trend continues into 1987, where the NHS is more or less self-sufficient in factor 9. So there is that period between 1984 and 1985 when patients in the United Kingdom who required factor 9 were using commercial products in significant amounts in a way that they hadn't done before. And we understand that, sir, to be a result of the introduction of heat treatment. The greater difficulty that BPL and PFL found in heat treating factor 9 led to I use the word neutrally, a delay in providing the factor 9 heat treated product. And during that time, either BPL was not issuing unheated factor 9 or had cut down on the amount of unheated factor 9 that it was issuing, or clinicians were not using that product and were instead turning to commercial factor 9, some of which by that stage was heat treated. Thank you, Paul. That is all I will say about that graph. That takes us to the end of the chronological part of the presentation. The next stage is to look at some of the themes and look at the data that we have on the amount of factor VIII that was produced across this period at BPL and PFL, the amount of plasma that was supplied to BPL and PFL, the capacity of BPL and PFL in theory to produce blood products, and also to look at the estimates that were made of usage across that period. I can begin that now, sir, or I can do it after a break. I'm entirely in your hands.
Well, I think perhaps we better have the break and come back to that. I see there's some nods. We'll have it in one go before lunch, presumably. So we'll take a break now and come back at, 20 to 12.